Hello everyone. Today we will discuss about insomnia and sleep-related breathing disorders classification according to the ICSD-3 guidelines. And we will see how the classificatory guidelines have changed over the years and what the guidelines presently are for these two disorders of sleep. We will proceed with the contents according to the following agenda. We will have a look of how the evolution of sleep disorders has been from ICSD-1 to ICSD-3 and now the ICSD-3 text revision. We will introduce ourselves to the ICSD-3 and take a look at the classificatory guidelines vis-a-vis the previous ICSDs and the latest one. The International Classification of Sleep Disorders is by the American Academy of Sleep Medicine, and it is the most advanced nosology of sleep disorder classification, which has evolved from ICSD-1 in 1990 to ICSD-2, 2005, and the latest in 2014. It is very important that we have a classificatory system which is valid and also in concordance with the other systems of classification, because that helps in appropriate clinical diagnosis as well as for research purposes. A valid classification, it serves to guide public policy towards advocacy, planning, and budgeting of different medical disorders. So the ICSD, which is the most used and the most comprehensive sleep disorder classification, has been revised. A text revision has been issued in 2023 June, which has features of updated information in the text, minor correction, and some criteria changes. The general structure of ICSD-3 parallels that of its predecessor, second edition. It has the same 6 clinical division. The pediatric conditions here are fully merged with each major clinical category under the paragraph of developmental issues, in which they have dealt with the pediatric aspect of the disorder as well as the geriatric aspects of the disorder, exception being obstructive sleep apnea, where the pediatric aspects have been dealt as a separate disorder. The 6 main clinical divisions are, as per the ICSD-3, insomnia, sleep-related breathing disorders, central disorders of hypersomnolence, circadian rhythm sleep-wake disorders, parasomnia, and sleep-related movement disorders. There is other category which has been included, namely the other sleep disorders where conditions which might not fit into the other above categories are assigned. Now, when we talk of insomnia, insomnia is one of the most prevalent disorders of sleep worldwide. And till the time ICSD-3 came up, insomnia was classified as primary and secondary insomnia as per the ICSD-2. But now all chronic insomnia conditions, they have been consolidated under the umbrella of chronic insomnia disorders. This has been a very big change as far as the ICSD guidelines are concerned, because the task force thought that whatever be the pathophysiology behind the insomnia, whatever be the reason, but there are certain maladaptive cognition and behaviors which are the perpetuating factors and need independent therapeutic management irrespective of the comorbidity. So it was clubbed into one single category. Another worry or another concern was that believing that insomnia is a secondary insomnia many a time led to uh, it led to inadequate treatment of insomnia, because it was considered that once the primary disorder was treated, insomnia will resolve by itself, which was many a time not the case. Again, because of all these reasons, the classificatory approach became on therapeutic basis rather than etiological basis, and that was thought more appropriate. Now, the diagnostic categories are the same as the previous ICSD, the frequency is 3 times per week. The duration criteria is of 3 months to state it as a chronic condition. And the fact that other sleep disorders have to be excluded before we can say that this is chronic insomnia disorder. The diagnostic criteria for short-term insomnia disorder is identical to the chronic one, except that the duration is less than 3 months and they lack the frequency criteria. Okay. So the ICSD-3 includes the following disorders of insomnia: chronic insomnia disorder, short-term insomnia disorder, other insomnia disorders, isolated symptoms and normal variants, excessive time in bed and short sleepers are the two other categories. So when we come to the chronic insomnia disorder, all these criteria must be met before we can state a patient has a chronic insomnia condition. The first one is the patient's caregivers or the patient parents or the patient himself, they report these one of the following conditions. Either they have a difficulty initiating sleep or a difficulty maintaining sleep, or they wake up earlier than the desired time. They have, if it is with regard to kids, then they have resistance going to bed on appropriate schedule, and they have difficulty sleeping without parent or caregivers. If either of these is present, it is criteria A. Criteria 1 is that whatever nighttime difficulties the patient have regarding to sleep, it leads to some daytime functional impairments by way of fatigue, malaise, attention deficit, mood disturbance, irritability, or behavior problems like hyperactivity, aggression in children, proneness to accidents. All these, uh, all these, one or more of these has to be present. Again, the condition should not be explained by any other sleep-related disorder. And again, the patient should have an adequate opportunity to sleep in a uh, comfortable bedroom and comfortable surrounding to sleep. So that is also a criteria which has to be met. And again, the frequency criteria of 3 times a week and for 3 months, the duration, then we can say that this is a chronic insomnia patient. Now, when we talk of short-term insomnia, the criteria are similar except that they don't have the frequency and the duration criteria. With regard to other insomnia disorders, so patients who complain of the typical insomnia features, they have difficulty sleeping, they have adequate opportunity to sleep, and they also have associated daytime dysfunctioning. So, but they do not meet the full criteria as we had looked in the previous slide for chronic insomnia or short-term insomnia, then they will be classified as other insomnia disorders. There is another category which is excessive time in bed. So it is proposed that these are isolated symptoms of insomnia. So there could be patients who have difficulty falling asleep, or they have prolonged awakenings during the night, or very prolonged sleep latency without a complaint of daytime consequences or any other sleep related complaint. So we are not going to classify them into insomnia or any other category, except that we will say that they are those who are having an excessive time in bed. Maybe people who are currently retired and from work, and they just spend a lot of time in bed because they're not bothered by the next day schedule. So this is one variant. This is one disorder here. Another category is short sleepers. So short sleeper is the category of individuals who sleep on an average fewer than 6 hours per night, yet they have no sleep-wake complaints. So they are perfectly normal short sleepers, and they no daytime dysfunctioning. This is a very, very small percentage of the population who are genetically predisposed to sleeping short, and that is not because of insomnia or a difficulty in maintenance of sleep. It is that they have a very small requirement of sleep, which is not as per the normative data, but then they are okay with it and they have a genetic predisposition towards it. So we will just categorize them as short sleeper, and they are not those with any insomnia disorder. Now, after insomnia comes the other very important disorder of sleep, which is also widely prevalent, that is the sleep related breathing disorders. change which has come up in the ICSD-3 compared to the previous classificatory guidelines by the International Classification of Sleep Disorder Association by the American Academy of Sleep Medicine is that now the ICSD is fine with the data that has come out with from the out-of-center sleep test with limited channels without the EEGs and the EMGs. That is now acceptable as a parameter to diagnose sleep-related breathing disorders, probably because a lot of home sleep studies are now being conducted. There are some limitations with it. One being that sleep disorder indices are underestimated because the denominator in the home sleep test is the total recording time rather than the total time. So many times they underestimate the severity of the condition. Another change has been the pediatric OSA criteria has been simplified and the signs and symptoms have been merged into one single criteria. Treatment emergent central sleep apnea is a new addition and has been included as a separate disorder. Now we should not be using the term complex sleep apnea, which used to indicate sleep apnea due to a lot of reasons, and that use is not discouraged. Another important thing to be noted before we proceed to the guidelines is that sleep-related hypoventilation disorder has now placed obesity hypoventilation syndrome as a separate disorder. Reason being it is widely prevalent and also it has certain unique clinical characteristics like daytime hyperventilation and hypercapnia. So, and those were the reasons that the task force placed it as a separate disorder. Again, the ICSD-3 disorders of hypoventilation have been separated from sleep-related hypoxemia as sleep-related hypoxemia might be present due to a lot of etiologies, irrespective of whether hypoventilation is present or not. Now, when we look at the classification of sleep-related breathing disorders, there are the following categories of obstructive sleep apnea disorders, obstructive sleep apnea in adults and pediatric, central sleep apnea syndrome, which is further divided into 8 subcategories as follows: central sleep apnea with shin strokes breathing, central sleep apnea due to medical disorder without shin strokes breathing, central sleep apnea due to high altitude periodic breathing, central sleep apnea due to medication, substance, primary central sleep apnea, primary central sleep apnea of infancy, primary central sleep apnea of prematurity, treatment emergent central sleep apnea, and we have sleep-related hypoventilation disorders, namely OHS, congenital central alveolar hyperventilation, late onset central hyperventilation, hypothalamic dysfunction, that is, we call it Rohat syndrome, idiopathic central alveolar hyperventilation, sleep-related hyperventilation due to medication and due to a medical disorder, hypoxemia, and isolated symptoms and normal variants like snoring and catatonia. Okay, we will proceed one by one and look at these important classifications from the ICSD and how we can classify a particular disorder as uh, like central obstructive sleep apnea adult. So A and B or the criteria C need to be satisfied. A is there has to be a presence of one or more of the following. One is sleepiness, non-restorative sleep, fatigue, or insomnia symptoms. Patient wakes up with breath holding, gasping, or choking during the night. Bed partner reports habitual snoring, breathing interruptions. This is very important. And earlier they had this category that patients should be having some kind of comorbidity like hypertension, mood disorder, CAD, but now it has been removed from the ICSD, considering the fact that presence of comorbidity is not a factor important enough to be a part of the categorical diagnostic guidelines. So that has been removed now. Another is that PSG or out-of-center sleep tests demonstrate 5 or more predominantly obstructive events per hour of sleep. And if none of this is present, and if only the criteria C is present, it will be an OSA, 15 or more predominantly obstructive respiratory events, apneas, hypopneas, or RARAs per hour of sleep during PSG per hour of monitoring or out-of-center sleep test. That classifies as adult obstructive sleep apnea. Now, obstructive sleep apnea, pediatric. then the criteria A and B must be met. Criteria A, it has to have either of the following: snoring, labored, paradoxical, obstructive breathing when you talk of the child, or sleepiness, or even kids can have manifestations like hyperactivity, behavioral problem, or learning problems. So any of these has to be present. Then we will say that it is meeting the criteria for OSA pediatric. Criteria B is PSG demonstrates one or more obstructive apnea, mixed apnea, or hypoapnea, but out of sleep. So because kids have they have limited respiratory reserves compared to the adults, and they manifest respiratory events much earlier as compared to adults with the same level of disturbances coming in the respiratory flow rate. So our criteria has been one or more obstructive apneas or hypoapneas or RERAs for kids compared to adults, where there is a criteria for 5 events per hour. Then the second one being that a pattern of obstructive hypoventilation defined as at least 25% of total sleep time with hypercapnia, which is partial pressure of carbon dioxide being more than 50 mmHg, in association with either snoring, flattening of inspiratory nasal pressure waveform, or paradoxical breathing. So if these are present, so either of these, then we can classify it as a pediatric sleep apnea. And along with the fact that the condition should not be better explained by any other medical or sleep disorder. Now, central sleep apnea syndrome is an entity with a lot of disorders into it. So when we talk about central sleep apnea with Shin-Stroke's breathing, so a lot of criteria have to be satisfied. There should be the presence of A or B, and C and D are compulsory. So A is the presence of the following symptoms: sleepiness in initiating, maintaining sleep, difficulty maintaining sleep, frequent awakenings, non-restorative sleep, awakening short of breath. Snoring has been removed as a criteria from all ICSDs for the central sleep apnea syndromes. There should be witness apnea. So if either one of these is present, it is criteria A. Criteria B is the patient has atrial flutter fibrillation, congestive heart failure, neurological disorder, because these are the conditions where the shin stroke breathing is present and the probability of CSA is high. Polysomnography demonstrates 5 or more central sleep apnea or hypoapnea per hour of sleep, and the total number of central apneas or hypoapneas is more than 50% of the total number of apneas or hypoapneas. So this is again very, very important. Point C has to be compulsorily there. Then the ventilation pattern should be that of Shin-Stroke's breathing, and it should not be explained by any other medical or sleep disorder or medication use. Then the criteria for Shin-Stroke's breathing, central sleep apnea, CSA with CSP. Now, CSA due to a medical or neurological disease without CSP. The criteria are pretty much the same. Snoring is not present. And a very important criteria is that disorder occurs as a consequence of medical or neurological disorder, which is a known disorder, but not due to a medication or substance. So we should be knowledge of the fact that probably the patient has congestive heart failure, the patient has a neurological condition which is causing the central sleep apnea. So that has to be very, very clearly defined. So now high altitude periodic breathing, CSA due to high altitude. The very important thing here is there should be all the criteria A to D must be met. There should be a history of ascent to high altitude. Then there should be the presence of one of the following. Then, of course, the one criteria which was witnessed apneas has been removed from the text revision. Maybe because many a time the onlookers' history is not uh, sufficiently ground enough to categorize as CSA due to high altitude. Then again, the symptoms are clinically attributable to high altitude, and if polysomnography is performed, it demonstrates central apneas or hypoapnea primarily during non-REM sleep. This has been added with a frequency of more than 5 per hour, maybe because non-REM sleep has a lower ventilatory drive, and as we ascend up And the person meets with hypoxia on high altitudes, because of which the patient hyperventilates, leading to hypocapnia, leading to uh, uh, central sleep apnea. Now that ventilation that is lower in the non-REM sleep and it's further worsens in the non-REM sleep itself. So these events are primarily observed in non-REM sleep, and that's one of the criteria. The disorder is not better explained by other current neurological disorder. This is one important medication, not substance. Now, diagnostic criteria for CSA due to medication or substance. The other criteria are very much the same for all central sleep apnea syndrome categories, except the fact here the criteria is added as a compulsory criteria that the disorder occurs as a consequence of an opioid or other respiratory depressant which the patient is taking and is not better explained by any other sleep disorder. So there is another category which is the primary central sleep apnea. So again, this is a very important category. So here there is no central shin stroke breathing present, and the central sleep apnea is more than 50% of total apneas, hypoapneas. There's no nocturnal hypoventilation and not explained by any other category. Now, primary sleep apnea of infancy is another criteria which is to be kept in mind when we are talking about the central sleep apnea seen in infants. The fact is that these criteria must be met. The first one being the apnea or cyanosis, as noted by observer, or an episode of sleep-related central apnea or desaturation is detected by monitoring. So the fact is that either an observer has to detect it or it has to be monitored, and hospital monitoring is the only acceptable monitoring in the postnatal period. Then it is over the age of 37 weeks when this criteria applies. Then polysomnography or alternative monitoring such as hospital monitoring shows either of the following. The home monitoring has been removed in the text revision because we have to be the more objective investigations as far as diagnosis is concerned. So this factor is the recurrent prolonged 20-second duration central apneas. Periodic breathing is seen for more than 5% of total sleep time after a chronological age of 3 months. And even if the central apneas are shorter, if they are associated with bradycardia or oxygen desaturation, that also is a criteria, and it should not be better explained by other disorders. Then primary sleep apnea of prematurity is one where central sleep apnea is seen with an infant with an infant who has a conceptional age of less than 37 weeks, and it is to be detected by hospital monitoring only, or sometimes even home monitoring is allowed here. So again, these are the criteria for the same. Treatment emergent sleep apnea has been added to ICSD-3 because it is a very distinct condition where the diagnostic polysomnography is showing 5 or more predominantly obstructive events per hour of sleep. So the patient has obstructive sleep apnea, which is diagnosed. However, during the use of positive airway pressure without the backup rate, the patient shows the resolution of obstructive events and the emergence of persistence or central apnea or central hypopnea with the following features. So the central apnea hypopnea index during the PAP treatment is more than 5 per hour, and the number of central apneas or hypopnea is more than 50% of total apneas and hypopneas. And one more factor that has been added is that because of these central respiratory disturbance indices, there should be some disturbance attributable to the in the daytime in form of sleepiness or difficulty in maintenance of sleep or during nocturnal awakening, short of breath or witnessed apneas, and no other condition better explains it. Now, obesity hypoventilation syndrome. This is diagnosed when there is hypoventilation during wakefulness with a partial pressure of carbon dioxide more than 45 mmHg, and this could be measured by end-tidal PCO2 or transcutaneous PCO2. There is presence of obesity, which means the BMI is more than 30 kilogram per square, or that is important, and hypoventilation is not due to any other etiology, being lung disorder or chest wall disorder or medication or neurological disorder. It has to be attributed solely to obesity, which is the cause of hyperventilation, and the following criteria should be met. So OHS is now a separate criteria. So diagnostic criteria for uh, congenital central alveolar hypoventilation syndrome is that sleep-related hypoventilation is present, hypoventilation during sleep is present, and most often it is due to the mutation of FOXP2B gene. Now, this is one more central late onset central hypoventilation with hypothalamic dysfunction. So these are the criteria that should be met for it to see rarely. Now, one thing which has been added is that diagnostic criteria have been added for sleep-related hypoxemia disorder. The difference being that polysomnography or home sleep testing or nocturnal oximetry showing that arterial oxygen saturation during sleep is less than 88% in adults and 90% in children for more than 5 minutes. However, sleep-related hypoventilation is not documented. And the fact is, ICSD-3 TR says that the desaturation is not fully explained by sleep-related hypoventilation, obstructive sleep apnea, or any other breathing disorder, then we will classify it as sleep-related hypoxemia disorder. Earlier, there was a little bit of confusion. This disorder, this entity called sleep-related hypoxemia disorder was not a separate entity. So many a time, a lot of disorders where only hypoxemia were present were put under the criteria of sleep-related hypoventilation disorders. So this has been classified and this has been categorized separately now. Now, there are certain isolated symptoms and normal variants which need to be known. One is snoring. So, it is a cardinal symptom of obstructive sleep apnea. However, not everybody who snores has obstructive sleep apnea. There are many patients who are primary snorers, and they do not have any daytime sleepiness or fatigue or fragmented sleep or any other functional impairment because of their snoring, and they do not have any choking, breathing pauses. So they can be classified as patients who are snorers and not patients with obstructive sleep apnea. However, if anybody snores, he doesn't have any daytime complications as well. But the presence of comorbidities like metabolic disorders like diabetes, hypertension, obesity, then we have to get a polysomnography done before we can categorically say this patient is a patient of snorer, or a patient of obstructive sleep apnea. Another important isolated symptom of normal variant is catatonia. This is sleep-related groaning, and it was previously included in the parasomnias along with the REM sleep behavior disorders, but now it has been shifted to the sleep-related breathing disorder section because one, it appears to be associated with prolonged expiration, usually during REM sleep, and secondly, it has been found that the use of CPAP has improved patients who have catatonia. The symptoms of catatonia have improved. So this was the classification of SRBD based upon ICSD-3. Now, to sum up, the ICSD-3 is an effort-intensive, comprehensive, and one of the most precise sleep disorder nosology. However, classificatory guidelines, they are undergoing further transition as the ICSD, they are all a work in progress. Now it is encouraged that medical or professional organizations, it is encouraging to see that they have worked together to achieve greater confidence and confluence between the different sleep disorder classification, be it the ICD, be it the DSM, be it the ICSD. So a lot of classificatory, there's a lot of confidence between these, and the categories are more or less similar. The classification defines appropriate avenues for future research. There are immense prospects for research on sleep disorders in India, and there is a need to harness those resources and those prospects so that we also can contribute to the growth of sleep science. Disorder classification is as such very important for the clinical diagnosis and for the management of any disease. So with that, thank you very much.